What are the key rules that have emerged to give you higher odds of success of getting to a successful finish?
We measure success based on one word, which is profitability as a health system. The margin is the mission. Said differently, if we don't make margin, we're not going to be able to fulfill our mission of helping our communities and our patients, right? And so with that lens, it's a pretty simplistic definition of ROI. Is this project going to be profitable or not? None of these projects is going to succeed unless they actually fulfill the mission or meet the problem statement. But you can measure adoption pretty quickly. I will say that we describe them as projects, not as pilots. Pilots really denote the potential for failure. If we have done the diligence, got the team assembled, if we've committed, it is part of our strategic objective. We'll be able to measure the downstream impact relative to the profitability of the organization.
Welcome to the Analyzing Healthcare podcast, brought to you by Scale Community. Scale is a global healthcare-focused member network where healthcare leaders come to connect, learn, share ideas, and shape what's next in our evolving healthcare landscape. To take advantage of all that Scale Community has to offer, from expansive content to virtual and in-person events to interactive peer networking opportunities and more, check out Scale Community at www.scale-community.com. Membership options range from free to paid, so if you enjoyed today's discussion, please take a moment to sign up for your preferred membership level. Welcome to the next Analyzing Healthcare podcast by Scale Community. I am pleased to be joined today by Mark Townsend, the Chief Clinical Digital Ventures Officer for Bon Secours Mercy Health. Bon Secours Mercy Health, my understanding, is one of the largest Catholic health systems in the country, 51 hospitals nationally, and about 1,200 sites nationally as well. And in addition, Mark is the president of the Medical Society of Virginia. So congratulations on that appointment, which I think occurred a couple months ago.
Yeah,
Formerly
thanks.
the Chief Clinical Officer at Bon Secours and formerly the Chief Medical Group Officer at Centra Health. So a lot of experience across clinical roles, digital roles, and just broader healthcare market leadership. So really excited for this conversation, Mark, and welcome to the podcast.
Well, thanks for having me, Jason.
So maybe why don't we begin with your personal journey, since it is an interesting one. You spent a long time seemingly on the clinical side and then more recently migrated over to the digital health side. And would just be curious what motivated you to make that jump and how you're sort of applying your skill set and your experience in this new role focused on digital health and technology within healthcare?
Yeah, great question. Life makes sense when you look at it through the rear view mirror and you look at what just happened. I think, going back 30 years ago, I would never have imagined being in the space I'm in now, and began my career intending to be a cardiologist, and specifically congenital cardiologist, so internal medicine pediatrics trained. To serve patients who are born with congenital heart disease. So doing that and recognizing that there was an up and coming specialty, adult congenital cardiology at the time, it was also essentially concurrent with the birth of, for example, the electronic health record. So dating myself and being there, in the front row seat and adopting and adapting to new technologies as it came on board, very much turned into the space of, okay, you've got a very specific patient population. How are you going to adapt technology to that patient population? And so it began with, for example, designing software that could help me do my job better in the space of reading echocardiograms. Imaging turned into then understanding credentialing and certification pathways specific to an emerging field in clinical medicine. But then it launched my administrative career concurrently. And so you start building programs in a new space. Next thing you know, you get asked to build another program that's a little bit tangential. Next thing you know, you find yourself very far afield from your original intent, and you still keep building programs. So my first administrative role, and this was now 3 or 4 years into my clinical career, my first administrative role was as a medical director of operations, or essentially a chief operating officer of an emerging heart and vascular institute. And so growing up administratively, problem solving, while concurrently then developing technology and adopting new technology, and quite frankly, figuring out how to pay for new technology to service my patient population, then led me to the role that I'm in now, where I serve as a change agent on behalf of our organization in the intersection of venture capital. We serve as a strategic investor through Acrete Health Partners. It's a tightly regulated space, obviously. So I've gotten involved in organized medicine over the years and I'm always working to understand our regulatory environment. But then we do some co-development of technology as well. So it's an interesting time and an interesting space. Add to that AI, and it makes for a lot of work to do on any given day.
So what's the structure? You've got Bon Secours Mercy Health System, the clinical delivery network. You've got the ventures arm, which you're involved with. You mentioned Acrete Health. Give us sort of an overview of what the purpose is of the ventures arm and how these different parties relate to each other. Are they integrated? Are they siloed? Is Acrete part of Bon Secours, or is it more of a separate partner that you work with? What's the lay of the landscape?
Yeah, lay of the landscape is Acrete Health Partners is owned by Bon Secours Mercy Health and is the venture arm of Bon Secours Mercy Health. Acrete Health also uniquely owns Nordic Global. So Nordic Global, an EHR implementation consulting firm, traditionally 60,000 clients internationally over the years, became part of the family through Acrete Health and therefore under the umbrella of Bon Secours Mercy Health. But we acquired Nordic and then turned it into our ITO. So through managed services, all of our IT division now resides within Nordic Global. And so it gives us access to do development. There's wicked smart people at Nordic, and they can do anything from, an RPA project to obviously, there's data expertise there, there's AI expertise. But that then really gets into the space within Bon Secours Mercy Health, the core health system. And my position is, having served as an operator and as a leader within BSMH, within core service delivery, acquainted with the people who are boots on the ground operators, right? And they know the problem statements of the health system. And so what we've done is we've gone to them, we've created a mechanism whereby we engage them and we ask them to bring forth their problems. And they bring forth their problems because we can help provide funding and do some matching essentially with emerging technologies or partnerships that are coming along the line. And so what we then do is use that as the investment thesis for a portfolio that is managed through Acrete Health Partners, again, on behalf of BSMH or Bon Secours Mercy Health. We serve as a strategic investor, typically after a technology is maturing, is scaling throughout our organization, obviously has met the value proposition put forward by the operators.
So, what does the venture arm always execute based on the health system's stated problem set? So, health system always has an operational need or operational or strategic, opportunity, and comes to the venture arm and says, "How do we solve this?" And you look out in the market and see what exists, or do you operate, maybe 50% of the use case is that, and 50% you're operating independently, just making good investments in areas where you see room for technology adoption in healthcare?
Yeah, it is. It is the former. So we are at this point really doubling down on an operational co-sponsorship, or a model whereby we are going to focus exclusively on the operational needs of BSMH. And we've done it both ways historically. We're working out of a second portfolio, and we've learned along the way that you can find essentially an emerging technology, a solution seeking a problem, and you can certainly generate a return for the portfolio, and your portfolio will perform. But there ends up being a credibility gap if you're a strategic investor as a health system, is what we found, and you've invested in a technology and you're not using it, right? You have to do some explaining. So why is it that you're not using the technology if you're an investor? And then there was this disconnect internally, quite frankly, with our operators who were saying, wait, you're investing in technologies that are cool, shiny objects, have great potential and have demonstrated value, relative to your portfolio. But what about us? And so people were starting to articulate that they felt left out. So we really doubled down on saying, okay, we're going to use this conversation to really engage our frontline operators and really meet them in their moment of need, and use that to serve as our investment thesis. It also puts us closer to co-development as well, because in many cases, people bring forward problems, and we'll get out, and do a market survey and have, good teams that help us with that. And then we'll find that, we're kind of in a unique space. So then we go down this path of co-development, again, kind of leveraging our Nordic relationship. We don't try to protect intellectual property, but what we do is we pre-negotiate terms of investment through warrants, for example, and then we create value together. And then we don't always, but then on down the road, we certainly have the option to invest. That's been our MO for the last couple of years. It seems to be working, and continue to iterate as the problems emerge. But so far, so good.
Yeah, it's interesting. We see a range of or spectrum of how these venture funds, hospital venture funds work. Some are tightly integrated into the operation, some more loosely. Some exist for, primarily financial gain for the hospital. Some exist primarily for operational needs for the hospital. It sounds like, Bon Secours is operating on the more integrated side and more focused on the strategic needs of the health system rather than the financial gains of the venture fund, although I'm sure that's important too. But it sounds like a secondary byproduct rather than the core primary objective.
Yeah, and we'll win on both fronts if we get it right, and we aim to get it right. Yeah, and it's interesting, the former part, the operational engagement, each of these projects actually has to live or die based on the success of any other operational engagement, right? So we're not going to create essentially a preferred pass or an HOV lane, if you will, for emerging technologies. They've got to come, and join our family, be part of our ecosystem,
Yep.
and prove their value from a traditional operator's perspective. And that really starts to become the differentiation relative to then, the potential for investing. Because if we can make it work internally, we know other health systems will be able to make it work as well. So it's a little bit of a pressure test as well.
I would love to hear a few use cases or examples, but before I do that, I want to jump to the end of kind of the rules of what works. I mean, when you think about tech adoption in health systems, there's a million areas you can focus on: clinical, non-clinical, and obviously those break down into all their different use cases across the life cycle of patient care, of the claim life cycle, so on and so forth, patient engagement. And there's a million reasons why you can fail along the way. Technology that doesn't work, lack of bandwidth, incorrect setup at the data infrastructure level at the hospital system, um, just competing priorities, cultural gaps. The list goes on. And so you have the vantage point, presumably of getting to the finish line of successful implementation, and we'll come back to sort of examples of that in a moment. But as you take through the entire life cycle from generation of an idea and deciding on which ideas to focus on, to selecting a vendor to work with, to bringing that implementation through to a successful finish, to measuring the ROI after that occurs, what are the key rules that have emerged to give you higher odds of success of getting to a successful finish? Or have we not yet gotten to a point where it's so scientific to have those rules emerge?
I think it's fair to say that the rules change as the technology changes. And certainly technology has changed over the past couple of years, with AI adoption. But we measure success based on one word, which is profitability as a health system, right? So as a health system, the margin is the mission. Said differently, if we don't make margin, we're not going to be able to fulfill our mission of helping our communities and our patients, right? And so with that lens, it's a pretty simplistic definition of ROI. Is this project going to be profitable or not? That then gets into some of the constraints, right? Constraints you can break into people, process, technology, for example, commonly used buckets. But the people part, back to using our operators to source essentially our investment thesis, that it speaks to engagement. And then you measure that engagement. It's one thing for an operator, a health system operator, to say, we're going to fix this. It's then, measured in terms of adoption. And love how you pointed that out, right? So none of these projects is going to succeed unless they actually fulfill the mission or meet the problem statement. But you can measure adoption pretty quickly. And for example, when you think back, just a common use case, could you live a day without your smart device or your smartphone? And people have adopted that. There's no going back, right? And so you can apply that to the projects that we've launched as well. And then you recognize with emerging technologies there are going to be hiccups. I think that's where we're learning real time to really define essentially expectations as we go into these projects. And I will say that we describe them as projects, not as pilots. Pilots really denote the potential for failure, and culturally, we're not about to do a pilot. We're going to do a project. If we have done the diligence, if we've got the team assembled, if we've committed, it is part of our strategic objective. We'll be able to measure the downstream impact relative to the profitability of the organization. So as we launch these projects, we're committing to success as we hit the ground running.
Second person in 24 hours who has pushed back on the use of the word pilot in the hospital system environment. And I guess what I'm hearing in that and learning is it comes back to these competing priorities. I think you want to, this is a question, not a statement, but I think you want to hear that people really mean that they want this and that they're very focused on committing to getting it to the finish line, both on the tech side, but also, frankly, on the hospital operational side. Because we have heard of a lot of examples where, we want something, there is an ROI, but it's hard, it requires change, and then it sort of, peters out as you're going through the process. So is that at the crux of project versus pilot, or is there sort of another component to this that I'm missing?
Yeah, no, I think you nailed it. And said differently, are you willing, as the accountable executive, to put your reputation on the line relative to the project? And actually, that's what we did. We built out the accountability, and we did that from, again, a profitability perspective, as we built, the mechanism to start to measure success. But you're accountable. So if you sign up for one of these projects, you brought it forward, you're passionate about the problem, not the solution, and then you're accountable actually as well. And so what you get in return is very significant visibility. You are the champion of this project, and you start to see it scale, and you see a lot of pride of ownership there. And then within my space, within our digital team, we don't own any of these projects. They are the projects of the health system. We are the enablers that make it possible and create the partnerships and, remove obstacles in the path in many cases.
Is there
And then we have
financial
created
ties when you talk about accountability? Like, does it run through the P&L of a division that ties to bonuses, or it's not at that level?
it is relative to the accountability of the operational ownership. So for a project to go forward from a financial perspective, we've created an acceleration mechanism, or we recognized a couple of years ago, listen, we're kind of in some cases cutting off our nose to spite our face, right? We all have fixed budgets, and then we're asking our operators to create an offset in a budget. They're going to kill something in order to grow something. So we created an acceleration fund, and we got word out there that, listen, we'll meet you halfway or more. So come to us, create us an offset in your budget, make it meaningful so you are accountable, right? You're accountable through P&L accountability, but then we'll match your funding, and we'll do that for 18 to 24 months. And so that has created this nimble environment where we're able to launch these projects in real time, not waiting for another budget cycle. But again, the discipline is, does this meet the strategic objective of the health system proper? And that has really turned that conversation into being more disciplined, quite frankly, as well, because we're rigorously pressure testing our strategy, not for now 2026, but for 2027, right? So we've got to be 18, 24 months ahead of ourselves here and now if we're going to actually launch these.
Healthcare leaders, if your revenue cycle management is underwhelming you, it's time to rethink your current suite of solutions. Scale Healthcare's AI-powered RCM solutions are purpose-built to protect and accelerate revenue across the entire lifecycle. Denial Shield is an AI solution that proactively prevents and automates the resolution of denials, stopping revenue leakage before claims are even submitted. Front Desk Shield supports preclinical, administrative, and front-end RCM functions, incorporating eligibility, prior authorization agents to eliminate friction early in the patient journey. Revenue Shield maximizes revenue by automating coding, charge capture, and revenue integrity functions, ensuring accurate and complete reimbursement. Together, the Shield suite helps organizations reduce operating costs, capture missed revenue, accelerate cash flow, and increase productivity without ripping and replacing existing systems. If you're ready for immediate ROI and measurable impact, visit scale-healthcare.com and see how the Shield suite is redefining AI-powered RCM.
Thanks.
Yeah, so it sounds like rule number one is, make sure there's an ROI in the theoretical objective here. Rule number two is ensure accountability and buy-in, not so much from a tech vendor, but really from the operational team. Rule number three that I'm hearing is, you said, make sure it's aligned with the overarching strategy, which to me, I translate to make sure that the return is meaningful enough, whether it's, it's not just positive ROI, it's meaningful positive ROI and meaningful strategic ROI. How do you think about that question? Because again, the health system with 51 hospitals, 1,200 sites, there's no shortage of ways and directions to go in. And so how do you, take what could be infinite in terms of use cases and bring it back to the level of an overarching strategy and sort of level of materiality?
Culturally, we have really doubled down on run rate improvement. And when you throw out run rate improvement, you're often making the assumption that, hang on a second, we're cutting our way to success, right? And yes, operational efficiencies have absolutely been accomplished through our run rate improvement culture. But what we've done is to say run rate improvement is grow your way to success. And so now in that vein of growing your way to success, you're going to maintain the operational efficiencies that we've accomplished through sweat equity over the past years, particularly emerging from the aftermath of the pandemic. But now what we're really doubling down on is to say, now we're going to grow our way to success as well. And so when you do that, you create this mechanism, and the we in this space includes our finance teams that have a project management, suite and office associated with them, but then also our strategy teams as well. And pretty nicely, you can start to prioritize essentially your initiatives relative to ease of implementation and relative to return. And then, using that approach, you can then leverage this culture of run rate improvement. You could call it rapid cycles of continuous improvement, but again, measuring it, in terms of the downstream value for the health system.
Is there a component of like, let's get some wins on the board and start small and, build up over time? Or really, the level of materiality sort of trumps and you're then focused on projects that are big, and big oftentimes equals complicated. So you're really taking on the big meaty stuff.
That's a great question. So in the space, you have to be willing to fail. And I like to say, and I've learned that you fail fast and fail forward. So as we launch projects, they have got to move quickly. Number one, I mean, they can't languish, in governance, and they can't languish in implementation, et cetera. So you get them up and running, you get them going. The nice part about having 51 facilities and 10 regional markets is we can spread these projects out, and we're not doubling down on one poor facility or one poor operational team. But as these projects come forward, again, they're coming from 4 different states and now 3 different countries. We're in Ireland. We're also in the Philippines as well for some of our shared services. So you're starting to then see the ability to distribute the wealth in this case, and I think it's a wealthy space, to be in these projects. And we're careful not to overburden any one given operational unit. But what we're doing is when we launch a project, it is 100% of the time believed to have the potential to scale, right? And so you measure success pretty quickly. Is it moving? And there have been times where it's not fulfilling its mission. There was a lot that we didn't understand, and you've got to walk it back. But that happens very infrequently. But it certainly has happened, and that willingness to fail fast, fail forward is culturally part of, I think, what makes us successful.
So let's get into some examples. So what are a few examples that you've been through that full process from idea generation to implementation to confirmation of ROI that you sort of tout as examples of success? And then what are 1 or 2 examples where you haven't reached that full end and a project has failed fast or failed slow, and what was the cause of that failure?
Yeah. So start with a win. And this one is just hot off the presses. We're doing this as we speak, but our first system level implementation of Agentic AI is in appointment scheduling, and it's a partnership with Hyro. And so we have a long history of using multiple different technologies, different mechanisms to do appointment self-scheduling, anything from, for example, building our own mobile app, which was going to be a direct competition to essentially MyChart. It made sense at the time. And so I'll use that as an example of failure in the theme of this conversation. So, we learned a lot, mostly what not to do. And having been in the rooms, as we were all very excited, and this would have been 4 and 5 years ago, we thought we were cracking the nuts specific to consumerism, self-scheduling of appointments. So then you take the lessons learned. That was a failure. We did multiple iterations of, all right, let's get this right. We're a MyChart centric, strategic self-scheduling shop. And then you also recognize that there are limitations of MyChart. And that's where Hyro comes in, the ability to do omnichannel scheduling. And so digital voice, obviously we've been doing web-based, and you can direct traffic into MyChart self-scheduling, but then SMS based as well. So this notion that if we're going to get this right, we're going to have to be able to schedule through any channel in this omni-channel, continuously available approach. And by the way, as we launch this, we're going to have to be able to launch this one at scale. And this one we did launch at scale. So that comes with, added pressure, if you will. But then it's got to be, again, the strength of our operational team and the partnership with the technology in this case, and the iteration of, hey, this doesn't work. Let's quick turnaround. We need this fixed within 24 hours. That type of a conversation. There's some tough conversations that happen, don't get me wrong. But as we do that, it allows us to then accomplish change at scale. And then we can measure success as well. And so the analytics, that are driving that implementation, for example, or anything from call center analytics to then satisfaction analytics to, then on down the line, numbers of appointments scheduled, cost per appointment scheduled, et cetera. I mean, and distill that all down to, again, one word, profitability, right? So that's an example of both success and failure in one story. And it's never over till it's over. And that will continue to evolve again as the technology evolves.
You mentioned about the EMR, which I would be curious to get your thoughts on. I mean, it's an interesting topic because if you look at all the narrative coming out from these EMR systems, they're positioned to take on more and more, more AI driven functionality embedded into the EMR. The bounds of what's covered in the EMR is, amorphous and, or said differently, expanding. So, things like scheduling, if you listen to the EMR vendors, will probably be covered as an EMR functionality. Things like coding will be covered. Things like scribing will be covered. Everything can be covered. Number one, what is your view on that? How realistic is that? And then number two, you're only able to make so many investments, take on so many initiatives, invest so much. How do you sort of think about making that bet about this functionality is in the near term roadmap for the EMR and I have confidence in that versus I'm not so confident and I need to fill a gap with another third party on top of the EMR?
That's a great question. So as you start down that path, I'm just using appointment scheduling as a functionality. We obviously are an Epic shop. We stop in, with Epic in every single one of these conversations, stay very connected. And, that connectivity is important for the success of, for example, a third-party implementation. And in this case, for example, appointment self-scheduling, you begin with, all right, how many of our patients actually have MyChart, right? And you're not going to hit 100% of our patients. And then of the patients who have MyChart, how many of them are willing to actually use it to schedule? And then what are we doing as a health system to improve the adoption? But then if you get to that, you take 100 patients, well, maybe only 60% of our patients are going to download MyChart and only maybe 20% of them are going to use self-scheduling. And how old are the patients that are doing self-scheduling? Are they, 18 to 26 or are they actually, in their 60s? And so with that is very much the connectivity that informs these conversations, because in this case, we're never going to get 100% of our patients signed up for MyChart, right? Maybe we will in the future, but then if we can't get them signed up for MyChart, then does it really matter that MyChart has this AI functionality and this digital assistant that's coming online will be Emmy? Well, Emmy will only work if you're logged into MyChart. What if you don't want MyChart, right? So then that's where, for example, we go back to say, all right, but we've got to be able to schedule for 100% of our patients. And yes, we're going to drive our MyChart adoption strategy through this. But the EMR, can it ever be all things to all people? I don't think it's ever going to be all things to all people. I think there's going to be natural gaps. It also gets into the space of how quickly can the large EHR vendors iterate and adapt. And, they're nimble, but third-party industry is clearly more nimble, right? And what we, I think, certainly hear from our third-party partners is when something becomes hot, that's when, for example, the EHR vendors start to take note, right? And in a reactive sense, start to say, hey, well, we'll build that out too. And so that's the space that we're in. Sometimes you can't wait. Sometimes we can wait, right? And then that gets down into the weeds of our financial analysis, relative to each of the problems that we're trying to solve. Do we have the luxury of time? Can we wait 18 to 24 months, for something to develop, or do we need to do it now? So all of those variables get into that space. Yeah, I mean, as much as I love Epic, I don't think they're ever going to be all things to all people.
When you purchase one of these products like the call center technology, how much is off the shelf technology where you're just going through a fairly straightforward implementation of a pre-existing product? How much is real customization of that product to your environment and also real preparation of Bon Secours Mercy Health System for implementation of that product? The data setup is messy. We need to clean it up before we can implement the product. So how easy is that implementation versus how bespoke?
Yeah. So if you've seen one health system, you've seen one health system, right? So it doesn't matter that technology has been implemented in 30 other health systems. Come on over and we'll do it again, and we'll have our own unique challenges. So there's that. And then pragmatically, it's nice to, again, have Nordic at our disposal to be able to help. And so we can do that in real time. But then you get past that, and then you start to get into the space of, well, back to co-development, and you're kind of referencing that. There are definitely spaces where we early on recognized there was an opportunity. We did a market analysis and then recognized that the technology wasn't going to get there fast enough. And so actually, as we're recording this today, I've spent most of our day with one of our partners, Brado, where we developed a digital assistant, and we initially developed it thinking we were developing a marketing assistant beginning in 2022. And so then as technologies changed, we conceptualized and launched this thing pre-Chat GPT, and have learned essentially how to keep pace of the technology as we've built and developed this technology. It is now so much more than marketing. It's a digital assistant that's a navigator. But then you sit down within the complexity of our health system and the multiple different overlapping initiatives and technologies. And that conversation gets into data integrity, and can we build out provider and physician profiles that are accurate? And can we use that data accurately in our websites? And is that going to actually fuel our provider directory? And is that going to actually, fully integrate into Epic and keep us real time relative to the nuances of putting in referrals? And what about credentialing and onboarding and then recruiting of physicians, right? So
everything's related. So
it's a big smelly onion sometimes, right? And the more layers you peel back, the more you cry.
Yeah.
But it is.
Are there use cases that you're seeing on the clinical side? They get into actual patient care, or is it primarily things like scheduling, marketing, non-clinical care, non-clinical services?
Love the clinical use case call out. Yes. So one of the projects that we launched last year, and I'll give the credit to one of our wicked smart operators and leaders, Brian Wyrick. He launched nursing ambient documentation. We've heard a lot about scribes and ambient scribes, essentially for physicians and providers. But we partnered with Epic and then Abridge in this case to develop nursing ambient. And so that is a very, very different form of documentation. It's clinical facing clinician. These clinicians, so our nurses, our largest clinical workforce, 12,000 of them throughout our health system. And it's hard to watch essentially physicians walk into a room and use the technology you can't use. So, however, to adapt that and build that to a nursing workflow is very different. Obviously nursing documentation is very discrete. So click and scroll and, document in specific fields. And so building it out, that has been a fun project that literally returns time to our nurses, our frontline clinicians, and we're figuring that out. And so that's clinical facing. That would be an example. And yes, we then have a smart facility strategy, and we're well down the path of trying to envision what agentic personas look like relative to digital clinician extenders, working under the license of our clinicians and doing a handoff from one to the next. And meanwhile, be patient facing throughout that whole continuum of care. So it's, again, a fun time to be in this space.
How do you think about risk mitigation with some of these new technologies, both clinical and non-clinical? So, there's a flaw in the technology, and a bunch of patients get pissed off about, improper scheduling practices. Use a coding technology and the coding is incorrect. And, what was an issue with one person now gets amplified across the board, or even worse, if it's, incorrect clinical documentation. But what's the protocol sort of for maintaining quality and for thinking about quality up front on things like a PHI and just other elements of risk as you work with these third parties?
So when you say risk, you're talking about governance, right? Because the two are interrelated. And so our governance is specific to mitigating risk and to being well informed. So first of all, understanding risk, begins at the inception of these projects. And for us to launch a project, one of the first stops we make is actually with a smart group of individuals that serve on a subcommittee, within our governance process to then determine risk and to it's not a decision-making body, but it's an advising body, right? So you go into these projects eyes wide open, and if the business case is such that we're going to adopt or we're going to assume more risk, then that's the business case, right? In which case we've got an accountable executive, and we're gonna pony up and make it work. But understanding the risk on the front end of the projects is super important. I think as a design principle, and I know as a design principle, our governance is predicated in this space, AI specifically, on saying that there is a human in the loop 100% of the time, right? So there is going to be, particularly with clinical applications, the clinician is using a technology as an extension of their license. The documentation reflects their own ability to maintain their own quality controls relative to their clinical practice. And then we can measure that as well, right? And so that then turns into, it's interesting, you're starting to use AI to follow AI to follow AI. So in this case, you can now start to use quality and safety mechanisms that use AI, to essentially keep tabs on performance as well. And so all of that is within the ecosystem as well. But there's got to be a human in the loop, and that human is assuming the risk. And there's an informed consent conversation as well that happens, particularly with patient-facing applications.
You mentioned about AI on top of AI. So I think what you're saying is it's a quality control on the AI.
Yes.
Have you thought about AI when it comes to people-driven quality oversight? Just using AI technology solutions as a way to scale, whether it's clinical or other forms of quality and compliance across the organization.
Yes, and yes. So quality and compliance, those are two specific use cases, but beginning with quality. So for example, we have internally what we will call safe care. It's our repository of near misses and quality and safety concerns. So, it becomes a data set, and any data set lends itself obviously to AI. So that's an internal project where we are evaluating that and evaluating the use of AI relative to because a quality insight does no good if it lives in one corner of one facility, in one market. It needs to actually be extrapolated and then scaled as well. So we need to scale the learnings and the insights. So that lends itself nicely to AI. And then from a compliance perspective, that gets into the regulatory environment and just keeping abreast of regulations, for example. That's another use case, right? So take our existing policies and procedures and then double check and cross-reference them relative to emerging regulatory constraints, if you will, or changes. That lends itself nicely to AI as well. So that's another problem statement, another use case. But yeah, it's not hard to find the problems in this space, right?
Yeah. Yeah, I want to end on a question of ROI, and I don't know that I'll phrase it that well, but I think everybody starts off with this goal of ROI, but I think in a lot of cases it's not that easy. You have a case like and I think it comes from the fact that human in the loop is a key piece of this. So you're not replacing people necessarily. You may be enhancing productivity, but if I gain an extra couple minutes for a person each day, have I really saved costs? And so there's ambiguity in some of these things. And I think part of the technology that's being implemented is also just to preserve scale and ensure quality with operations, whether it's in the clinical side or non-clinical side. It's not meant to save money. Maybe it leads to better performance, better accuracy. And so, yeah, I guess my question is, I see this a lot where, we start off with ROI, but the ROI is not that easy to measure. There's sort of a bid-ask spread between the health system that wants to implement the technology. It says, maybe to the vendor, come at risk. The vendor says, yeah, but I'm going to be implementing for a year, and it's not that easy to isolate for the KPIs. So, they're hedging, rightfully so. Everybody's acting rightfully so. How do you think about ROI in that sense? What's your reaction to that? How do you think about, how much the hospital is willing to go at risk to take a journey to find out whether something is worth implementing versus putting that on sort of the vendor for an at-risk engagement?
Well, begin by saying that you're completely accurate in that ROI is not easy to calculate, right? And so we went down the path a couple of years ago with very sophisticated CFOs who were doing a heck of a lot of work to put together these very elegant models of essentially trying to calculate an ROI per project. And we took some highly visible projects. At the end, you have a very complex spreadsheet, and there are lots and lots of assumptions, and you have to get in and toggle assumptions, right? And so maybe this, and there's allocations as well, and it becomes very complex. So at the end of the day, and this is how I found myself in this space as well as a congenital cardiologist, it's all about numbers and numbers telling a story. And so the way my brain works is more in a cost accounting construct. What we did was we took these ROI demonstration projects, essentially these beautiful, elegant spreadsheets, And we started to look at the assumptions, and then it turned into, can we scale that? And the answer is no. We couldn't scale essentially what we were doing across the ecosystem. And so then we said, well, let's zoom way out. So if we're driving profitability through these projects, what if we focus on profitability? And back to costing, we went to our costing team and said, unit level accountability, we can do that, right? So drive essentially performance for these projects by determining the operational owner, creating the accountable unit, and you can do that within Strategize, for example, and then just trend profitability over time and trend it on a quarterly basis. And we know when a go live happens, and then if things are going well, guess what? We're going to trend favorably.
Don't focus on the micro, focus on the macro, and therefore contain the number of experiments you have or projects you have going on at any one point in time so that you can point to it. But if the aggregate looks better, then that's good enough.
Right. And if you're a profit center, guess what? You're more profitable. If you're a loss leader, you're losing less. Right. And so you can still trend margin either way. And that's speaking the language of our operators again. Right. And so what we're doing is trying to conform essentially the accountability, the P&L accountability, but then how they're going to be measured in terms of their performance. We're conforming that to what they're used to, which is their P&L accountability, right? And so being able to measure that and transparently then report that back to the operators in a supportive fashion is what we're working hard on, and we're getting there. So that's another project.
Do you think that, this is a loaded question, but being a nonprofit, that you're at a disadvantage with that aspect of trying to maintain profitability at a clinic level? Or, at the end of the day, even if you're a nonprofit, it's still core that you need to maintain profitability?
I've asked myself that question several times, and I stay close to friends in for-profit medicine. I think each of us have kind of our unique constraints and environments. While we're not answering to a board of shareholders, the community benefit that we're demonstrating is equally rigorous, and essentially relative to our mission is again the metric by which we're going to succeed or fail. And I think the mechanisms or the infrastructure sometimes varies a little bit. I think in for-profit, what I see from my side of the fence is the appetite for risk sometimes, I believe, is a little bit less. And in not-for-profit, you've got that compelling mission, particularly faith-based healthcare. But there is the mission, right? And the mission is very compelling relative to supporting vulnerable populations. And in many cases, we will take a calculated hit because it's the right thing to do. I think that does differentiate for-profit, not-for-profit. And you see that with what I call the intrusion of private equity into the healthcare acquisitions. In some cases, we're venture capitalists, right? Not picking on PE, but maybe picking on them a little bit. The margin is the mission there, but it feels different than when we say it. So I think there is some differentiation there. Again, one's not right, one's not wrong. Yeah. It's just different.
Yeah. So one aspect that's interesting in what you're saying is that maybe the for-profit actually creates some inertia because you're more rigid on what you can invest in and why. And on some of these projects that have broader, more amorphous objectives that are still very important, you may actually have an advantage as a nonprofit. So that's an interesting perspective. So I hadn't actually thought of it that way.
Well, and if you apply that, Jason, to service lines, and you look, for example, at what service lines for profit support versus not for profits, like women's and children's is a loss leader, right? And you predominantly see, the best place to have a baby is usually the not for profit in any given community. It's not necessarily the for-profit health system. And increasingly, you're seeing labor and delivery units closing. And we've, needed to do some of that in our own, competitive markets as well. But back to, that mission, can we take one for the team on behalf of the community relative to our mission? We're not fulfilling our mission if we're not going to do that. And we measure that, right? And that's part of our culture. We're very proud of our community benefit.
Yeah. Mark, I want to thank you so much for the time, and I appreciate all the insights and sharing a bit about how you are thinking about integrating technology into Bon Secours Mercy Health.
Well, thanks again, Jason. Fun conversation. Appreciate it.
Thanks so much.
Thank you for joining us on Analyzing Healthcare. Stay informed and stay inspired. Don't forget to subscribe and visit scale-community.com to become a Scale Community member. Until next time, keep exploring the ideas that shape our healthcare systems.